Hello everyone, welcome to Dr. Ekram Explains today. Today our topic is approach to headache in adults. Headache is common. It is one of the most common neurological manifestations and it affects almost everyone at least once in a life. But the good news is most headaches are benign or harmless, but some are due to life-threatening causes. So our aim is to identify the danger features and classify headache correctly. Now, types of headaches. This donut curve shows the basic two types of headache. You can see primary headache shown in blue color cover 90% and secondary headaches shown in orange color are only 10%. Among the primary headaches, tension type headache and migraines dominate. But clinicians must stay alert to secondary causes like hemorrhage, infection, or raised intracranial pressure. Now, primary headaches. Primary headaches are syndromes themselves. Secondary headaches point to pathology elsewhere. Among the primary headaches, these three are most common: migraine, tension type headache, and cluster headache and other trigeminal autonomic headaches. Tension type headache is most common population-wide, but migraine is most common in clinical setting. Now, secondary headaches. Secondary headache can be due to a structural, vascular, infectious, metabolic, or drug-related causes. Always remember, secondary headache is due to something else which is not good. It can be due to bacterial infections in the brain meninges, can be due to bleeding in the brain or tumor in the brain, or due to some problems in the neck joint, or it can be due to drug related. So always remember, secondary headache is due to a structural, vascular, infectious, metabolic, or drug related. Now, primary headaches. This table shows different features of primary headaches. Note there are overlaps between different types of headaches. Migraine is the commonest diagnosis in clinical setting, but tension type headache is more common population-wide, which I have already told. If you look at this table, there are different manifestations, durations, and associated symptoms are shown. So in migraine, the key feature is unilateral headache. It is pulsatile and aggravated by activity. But in tension type headache, it is bilateral. The feeling is a sense of tightness or pressure, and it can be from mild to moderate in severity. The cluster headache is usually unilateral orbital and it is very severe. And you can see that there are variations in duration of different types of primary headaches. Migraine usually lasts for 4 to 72 hours. Tension type headache can last from 30 minutes to 7 days, and cluster headache is usually 15 minutes to 3 hours. Regarding associated symptoms, migraine is usually associated with nausea and photophobia, phonophobia, and other manifestations. In tension type headache, usually there is no nausea or other such manifestations. But cluster headache can be associated with different autonomic manifestations. Secondary headache. Secondary headaches, always remember that 5 to 10% of headaches are secondary, but recognition is important because it saves lives. Common causes of secondary headaches are subarachnoid hemorrhage, meningitis, giant cell arteritis, intracranial mass, or drug withdrawal. So, if we summarize it, it can be due to trauma, vascular lesions, infections, or tumor. It can be due to medications, metabolic, or systemic disorders. Also, it can be due to cervical or ocular pathology. So remember, secondary headaches are always due to something else wrong in the brain somewhere, or in the eyes or associated structure. In this part, I will cover history and physical examination. So headache evaluation is a reasoning exercise, not a reflex to scan. So use history to differentiate between benign primary types and those requiring urgent workup. Imaging is warranted only with danger features. So the steps can be described step by step. In step 1, you have to exclude secondary causes and emergencies. For example, if you suspect the patient is having subdural hematoma or subarachnoid hemorrhage, then this is a case of emergency. So you have to deal emergency cases likewise. And then step 2, after separating the emergency cases, you have to classify primary versus secondary based on history. Step 3 is the pattern recognition. What is the pattern of pain and associated features? And the next step is to investigate according to history. If there is any red flag or danger sign, then you have to do the proper investigation for those cases. Now, key elements of history. History is the diagnosis. Clarify the characteristics of the presentation very carefully. For example, onset and course. What is the onset of headache? Is it sudden or gradual, progressive or episodic? So according to onset and course, you can justify what will be the type of headache. Then look for the character and location of pain. Is it pulsating or it is feeling like a pressure? Is it unilateral or bilateral? Also look for the associated symptoms. Is there presence of nausea, photophobia, phonophobia? Is there any visual aura? Then what are the triggers and relievers of pain? Some patients may be feeling pain when they are stressed or they have sleep disturbances, maybe related with position or certain foods. So you have to ask very carefully about these conditions, which are the triggers and which are the relievers of pain. And then also assess the impact of pain and causation or disability. Certain type of pain can impact work function and also may be associated with medication use, certain drugs. So you have to ask all the medications used by the patient. So after taking a proper history, you have to go for the neurologic examination, including physical examination. And abnormal findings can give clue to secondary etiology. So physical examination and neurological examination has to be very thorough. So first start with vital signs. Look for the blood pressure. Is the patient hypertensive or not? Look for the pulse rate, rhythm. Is there any changes in rate or rhythm? Is the patient febrile? If the patient is febrile, then you have to look for the signs of meningism. And palpate the temporal arteries, neck and shoulder muscles. Because in certain conditions, you will find that the muscles are very taut, which indicates the patient is very stressed. Temporal artery may be tender in giant cell arteritis. Also inspect the fundus and for papilledema and optic changes. And this is a very important clue to the underlying cause of headache. And then you have to do a proper full neurologic examination. Examination of the cranial nerves, examination of the motor system, examination of the sensory system, examination of the gait, everything about neurology. And as I told, note the tender spots and look for the autonomic signs. So a proper full neurologic examination and a detailed history actually will give you 80 to 90% of the diagnosis. And after taking proper history and physical examination, you can actually identify the low risk patients. That means patients with benign headache. And the features of low risk or benign headaches are patients are younger, usually less than 50 years of age. And you will find typical migraine or tension type pattern of headache. The course is stable. Patient will claim that it is happening for the last few months or even years. And neurologic examination will reveal no abnormality. And there will be no systemic illness or no new findings. So by eliciting the important history and findings, you can actually stratify the patients. Is it low risk or high risk patients? For identifying the secondary headache causes, you have to use the Snoop 10 mnemonic, which is very useful to detect secondary causes. Snoop 10 usually stands for, S is for systemic symptoms, that means fever, weight loss, etc. N for history of neoplasm or tumor, and N for neurologic deficit. O for onset. If the onset is sudden, then actually you have clue to certain type of headache. For example, thunderclap headache. O for older age. If patient is more than 50 years of age, then you should suspect some secondary causes. And P for pattern change. Is the patient having progressive pain, or there is certain change in pattern of pain? If there is change in pattern of pain, that is a very important clue. And 10 other features starting with P, that is posture, pregnancy, post-trauma, papilledema, painkiller overuse, etc. So by asking and looking for these important clues and causes, you can easily identify secondary headaches, and you can confirm it by investigation then. So this is in short history and clinical examination of headache, and by taking proper history and doing a proper neurological and general examination, you can actually diagnose and identify most of the headaches easily. So this is in short the overview, history and clinical examination for headaches. In the next part, I will cover clinical investigation and management. Please keep tuned for more contents to come, and press the bell icon and subscribe to this channel if you like it. Thank you. So let's start approach to headache in adults part 2. This part I will discuss a diagnostic approach which will include investigations and next treatment. So after taking proper history and doing the clinical examination, you can determine the provisional diagnosis, and also you can formulate some differential diagnosis. In 90% cases or more than that, no investigation is required. But if you suspect any secondary causes, or if there are danger signs, as I mentioned, Snoop 10, or if you find any abnormal findings on examination, then you have to do the investigation. And imaging is a very important investigation in neurological evaluation of headache. The aim is to identify secondary causes like tumor, bleeding, infection, or raised intracranial pressure. So you have to choose the test based on urgency and clinical context. So choosing the right modality of investigation is important. So this table shows the setting, preferred test, and key rationale for doing that. In most of the emergencies for identifying bleeding or tumor rapidly, CT scan of the head and contrast, with or without contrast, are preferred. For non-emergency conditions where soft tissue lesions or posterior focal lesion is suspected, MRI of the brain can be done. But if you suspect aneurysmal lesion or any vascular lesion, then CT angiogram and MR angiogram is necessary. And for sinus or facial pain, Where local disease assessment is necessary, you can do the CT sinuses or temporomandibular joint. Sometimes plain X-ray can be helpful. Lumbar puncture and laboratory tests. So lumbar puncture and examination of the cerebrospinal fluid after a normal CT scan is mandatory if subarachnoid hemorrhage is suspected, and this is actually very important to rule out subarachnoid hemorrhage. And also for infection, inflammatory or idiopathic intracranial hypertension, lumbar puncture should be done to test cerebrospinal fluid. You should check the opening pressure and CSF composition in these cases. And other laboratory tests like erythrocyte sedimentation rate, C-reactive protein, these are very high in giant cell arteritis, those above 50 years of age. Also, you can do the common tests like complete blood count, blood glucose, and also do the renal function if you suspect systemic illnesses. Now let's consider some special clinical scenarios. For example, in older age, those above 50 years of age, giant cell arteritis must be considered. Giant cell arteritis usually shows high erythrocyte sedimentation rate, and temporal artery biopsy and histopathology should be done to confirm it. In case of pregnancy, you must rule out preeclampsia by taking proper history, physical examination, and investigation as necessary. Also in pregnancy, cerebral venous thrombosis or CVT is common. So MRI and MRV without any contrast should be done. If the patient has fever with headache, always think meningitis or encephalitis. And in case of post-trauma or postural pain, consider CSF leak or subdural hematoma. So these are few special clinical scenarios which should be considered while planning for the investigations. So putting it together, what is the evaluation algorithm? It starts with initial assessment by taking history, doing proper examination. You can identify primary versus secondary. If there are red flags, you have to do urgent CT scan, MRI with or without lumbar puncture. If the patient is low risk, you can manage as primary headache per type. And always re-evaluate for pattern change or treatment failure. I will explain today management principles and special considerations. So at first, we have to understand what are the goals of management in headache. First, we want to relieve acute pain and restore function. Number two, to prevent recurrence and reduce disability. Third, identify triggers, and avoid medication overuse. And finally, educate and reassure the patient by setting realistic expectations. So in summary, acute relief, prevention, trigger control, and education. So first, acute treatment of primary headaches. This table shows the basic management plan. In migraine, acute therapy must be taken early in the attack and try to avoid combination of analgesics and opiates. Cluster attacks respond best to oxygen or triptans. Triptans are a class of prescription medications used to treat acute migraine attacks by activating serotonin receptors to constrict blood vessels and block pain signals. They are recommended for moderate to severe migraines that do not respond to over-the-counter pain relievers and can help with symptoms like pain, nausea, and sensitivity to light and sound. Due to their blood vessel constricting effects, triptans are not recommended for patients with cardiovascular problems or cardiovascular diseases. About GPANs, GPANs are a type of medicine designed specifically to help treat and prevent migraine. GPANs are also known as CGRP receptor antagonist because they work by blocking the action of a chemical called CGRP. CGRP stands for calcitonin gene-related peptide. It is a chemical that is known to be associated with migraine attacks. Now, I will discuss about preventive or chronic therapy. Preventive therapy is indicated when attacks are frequent and disabling. You can use different types of drugs, which are shown here one by one, but choose agents based on comorbidities and patient's need. Monoclonal antibodies or MABs in migraine are a class of targeted therapies that block the calcitonin gene-related peptide or CGRP pathway and thereby reducing the frequency and severity of migraine attacks. Always emphasize on adherence and follow-up to assess the benefit. And reassess the condition after 8 to 12 weeks. Now, a little bit about medication overuse headache. Medication overused headache is a chronic daily headache caused by the frequent use of acute pain medications for primary headache disorders like migraine. And it creates a cycle where the medicine to treat a headache becomes the cause of more frequent and severe headaches. To be considered for a diagnosis of medication overuse headache, a patient must have a headache for 15 or more days monthly with an established diagnosis of a primary headache disorder like migraine or tension type headache. Additionally, they must be utilizing one or more symptomatic medications regularly, that means 10 to 15 days per month, depending on the type of drug consumed, and for over 3 months. They must use the drug for more than 3 months. So the management is withdrawal of the offending drug and add supportive therapy, and always try to educate the patients early so that they don't have to face the condition. And also use bridging medications like naproxen or steroids during withdrawal. Now, a very important consideration for management of headache is lifestyle interventions, because this has a great impact. So always try to identify and avoid the triggers like stress, sleep loss or dehydration, and dietary factors. And encourage regularity of sleep, regularity of meals, and exercise. And then patient can keep an headache diary. Headache diary actually is very helpful to monitor the frequency and response to treatment. And the vital part of headache management is regular follow-up for medication review and patient education. Now I will consider some of the special headache syndromes. Number one is thunderclap headache. This is a sudden, severe, worst ever pain and peaks within minutes. Always think about subarachnoid hemorrhage until proven otherwise. So this is a medical emergency. Other causes include venous thrombosis, aneurysmal dissections, and other conditions. Remember, thunder means danger rule, and immediate CT scan and lumbar puncture may be required. There is another group of headaches which should be considered under special conditions. This is raised or low intracranial pressure headaches. So in this table, the characteristics of raised or low intracranial pressure headaches are shown. In case of raised intracranial pressure or idiopathic intracranial hypertension, the key feature is the pain is worse in the morning, aggravated by cough, and you will find papilledema on fundoscopic examination. The typical group is obese young female, and patients require MRI and lumbar puncture. And on lumbar puncture, opening pressure is high. In case of low intracranial pressure headaches or CSF leak, pain is relieved by lying flat, and the pain is diffuse, and this can happen at any age. Here, MRI with pachymeningeal enhancement is necessary. Now, headache in special populations. First comes pregnancy. So in pregnancy, headache might be due to preeclampsia, CVT, or pituitary apoplexy. In older people, those who are above 50 years of age, mostly it is due to giant cell arteritis, which can be confirmed by biopsy and histopathology of temporal arteries. And post-traumatic headache is usually due to subdural hematoma or cerebrospinal fluid leakage. If headache is associated with fever and neck stiffness, always consider meningitis, meningoencephalitis, and appropriate investigations and management are mandatory, like lumbar puncture with antibiotics. Now, some pitfalls in management of certain chronic daily headaches. So, headache more than 15 days per month for more than 3 months. Always think about chronic migraine, chronic tension type headache, or medication overuse headache. And these conditions might overlap. So, overlapping or evolving from episodic type to chronic daily headache is not uncommon. And always exclude secondary causes. And this is first priority. Always exclude secondary causes. And manage via prevention and withdrawal of overused drugs. So, summary and take-home algorithm is always start with history and try to identify the pattern. Pattern recognition is the cornerstone. And check for red flags. As I mentioned, Snoop 10. Snoop 10. You can identify the secondary causes of headache. You have to decide, is it primary or secondary? And imaging should be done if needed. And treat acutely and plan prevention. Then educate the patient and review regularly. So the outline is very clear. Start with history, do the necessary physical examination, identify the risk factors, do the investigations as needed, manage and review. So thank you. This is in short clinical evaluation and management of headache. Please keep tuned for more contents to come. Press the bell icon and subscribe to this channel if you like it. Thank you again.